Hello and welcome. Welcome to our presentation today to talk about Delaware's End-of-Life Options Act. We are so pleased that you chose to spend this time with us today. We know there are lots of other things that you could be doing and probably need to be doing, but we're so glad that you are with us today. Today for this presentation, we do offer live captioning in both English and Spanish, and so that is available for you if you need it. To access the captioning, you can enable it at the bottom of your screen by clicking on the double C's and follow the prompts from there. If you have any questions throughout the program, please use the Q&A box, which is located at the bottom of your screen. No need to raise your hand. We will take questions directly from the Q&A function after or towards the end of the presentation. We will be leaving some time for Q&A, and we will aim to address as many of your questions as time will allow us. And lastly, this webinar is being recorded and will be sent out to you all by email. We will also have it available online to view on demand, or if you'd like to share it with your colleagues, your community, or someone else. And so with that, we are excited to get started today. Before we do, I want to take a moment to acknowledge we are here today to talk about Delaware and the new law available in Delaware for people to be able to access the option of medical aid in dying. When Governor Meyer signed the Ron Silverio and Heather Block End-of-Life Options Act on May 20th, 2025, Delaware became the 12th jurisdiction in the United States to provide terminally ill adults the option of medical aid in dying. This milestone was the result of over 10 years of outreach, organizing, education, hearings, and tough conversations by hundreds of advocates and professionals and passionate supporters, and we are so grateful. In that time, we learned that 72% of Delaware residents support medical aid in dying, as do 74% of physicians in Delaware. We also saw incredible support from the Delaware Nurses Association, the Delaware Coalition of Nurse Practitioners, countless social workers, faith leaders, doulas, and other community professionals. We are grateful for everything that went into where we are now, which is working on implementation in Delaware and providing professionals with the information they need to support their patients at the end of life. Joining me today are two amazing physicians that are not only full of wisdom and experience, but as you will soon see, full of tremendous heart for patient-directed and patient-centered care at the end of life. Panelists, would you please introduce yourself?
Hi, I'm Diana Barnard, and I'm joining you today from Vermont. And I am a board-certified hospice and palliative care physician, though I started my career as a family medicine doc. And I've been working with Compassion and Choices since 2000, when we first started working on our law here in Vermont, and have done a lot of education and had the opportunity to do some advocacy, including in the great state of Delaware. So I'm grateful to be here. Thank you.
Thank you for being here.
Hi, everyone. Welcome. My name is Sonja Richmond. I'm a board-certified internist and a boarded hospice medical director. I am currently Chief Medical Officer at a hospice organization in Northern Virginia. I am licensed in DC, Maryland, and Virginia, and had the pleasure of caring for one of the first patients in DC receiving medical aid and dying care. Since that time, I've happily joined forces with Compassion and Choices, advocating, speaking in any opportunity and in any atmosphere for end-of-life care options. Thank you all for joining, and I'm happy to be here.
Thank you. I'm so glad to be here with both of you and in conversation with both of you. My name is Jessica Empeño. I am a medical social worker with advanced certification in hospice and palliative care. I come to you from California, where I have worked in the community, worked in hospice and palliative care, supporting people at the end of life for over 25 years. And I am part of the team here at Compassion and Choices, where I am the national director of our clinical engagement, which really focuses on supporting professionals to make sure that they have the information and the resources and the support that they need in their work with patients. Compassion and Choices is the nation's oldest, largest, and most active nonprofit organization that is committed to care and expanding choice at the end of life. For more than 40 years, we've been doing this work, and we have provided support and resources for individuals and communities while working to advocate for patient-directed policies, practice, and care at the end of life. I want to take a moment very quickly to just kind of level set for our conversation today. And I want to make sure it's known that this event is catered specifically to professionals. We are talking to healthcare professionals, and we will be using language and terminology that will be familiar to professionals. So in this particular presentation, we're not necessarily speaking to individuals. So if you are looking for information for the option of medical aid in dying for yourself or for a loved one, you'll have to determine whether this is the best conversation for you. We did do a webinar a couple of weeks ago, hosted by our very own Heather Pope, that is available on the CNC website. That would be a wonderful place for you. Also, we will be hosting another conversation where I will be talking about medical aid in dying more broadly and generally, and we'll be talking about how to access what you need to do, what those tips are for accessing medical aid in dying in an authorized jurisdiction. So for today, we will not be providing any medical advice. We will not be able to address specific situations or concerns. We will be sharing resources and information really targeted to professionals. We will also be sharing additional resources in the follow-up email along with the recording of this webinar. And keep an eye on the chat. I have a full team of CNC amazing folks with us today that will be assisting with questions, but also posting links to resources and highlighting things that we talk about here today. So with all of that, what are we talking about today? So we are going to be talking about the clinical practice of medical aid in dying. We will be providing resources for more learning and information specifically tailored to help you in support of your community, your clients, and your patients. And the hope is that by the end of our time today, that you feel a little bit more comfortable with what medical aid in dying is and confident in discussing this option with your patients and with your colleagues. So very quickly, as we get started, we'd love to get a sense of your comfort level and how familiar you are with the clinical practice of medical aid in dying. So we're going to launch a poll here very quickly to just get a quick sense. Among those that are with us today, I know we have nurses, nurse practitioners, so we have folks that work in acute hospital settings, we have folks that work in community care and residential care. So we have a great diversity of folks joining us today. So let us know, how familiar are you? All right, so it looks like we have some folks that are familiar, but maybe more somewhat familiar. All right, thank you so much for that feedback. I'm going to hand it over to Dr. Richmond from here.
Thank you, Jessica. One question that we often encounter in our own individual lives, as well as in speaking with the patients that we care for as healthcare professionals: how do we want to experience death? I can speak for myself, and my goal and my job is to empower the patients that I care for to allow them to speak on their own individual desires as to how they want to pass. These are options, these are choices, and this is your end of life journey. While this is not a one size fits all, what's most important, I would say, is the unifying theme is autonomy. The unifying theme is understanding that our decisions in our end of life care is varied. It's individual, it's heartfelt, it's consideration for your own individual family. But some of the common terms or common concepts that I often encounter, and you all may encounter as healthcare professionals: some people want to experience death at home, near loved ones, and surrounded by loved ones. Pain and discomfort managed. Spiritual needs, and ultimately your values expected and respected. To feel safe, to feel comforted, and let me add to that bullet point, to feel heard, and overall peace. And this is important for us to ask as healthcare providers: how do you want to experience death? And to be very careful about not imparting our own desires and ways that we want to experience death. As we transition to our next slide, dying changes its face constantly. We are revolutionized, we are enhanced, we are also in an environment of being more informed. Thank you, Compassionate Choices. It changes in how, where, and why we die. The discussions regarding ethical practices in death and dying. Patients ultimately refusing certain interventions that we have become accustomed to as physicians and as providers, is most important. Do we want respiratory support, artificial nutrition, and examples? I'm going to hand this over to my partner, Dr. Barnard, to complete the rest of these bullet points, to share her insight on the changing face of dying. Thank you, Diana.
Thanks, Sonja. Yes, I think, it's so important to remember, how and why we got here, and that the circumstances under which the cause of our dying changes over time. In many years past, we died much more suddenly of accidents or illnesses that we had very few tools to treat. And what's happened with the success of medicine is we've developed many tools that help save lives and extend lives. And that's absolutely to be celebrated. Things
Mhm.
like common use of ventilators and artificial nutrition. Those same tools, however, we've also seen, that when they are useful and when they become burdensome, and when are they supporting life and when are they interfering with death, these discussions around the ethics and the morals of, is it okay to use ventilatory support? Is it okay not to use ventilatory support? Is it okay to start an intervention and then stop it if it's not working? These are the kind of ethical and moral conversations that medicine brings to us as it develops. And so medical aid in dying, I think, really has grown out of that movement. And it also is true that we are really learning, in a much more broad way, the different ways in which people can suffer when they have a more prolonged final chapter of life. And I want to give you just a brief case to really make this point. So you can advance the slide. I'm going to tell you the story of John. And John asked me to tell his story, and he asked me to use his name. And John was one of the first patients I took care of after our law passed in Vermont. And he was a 94-year-old World War II veteran. He was incredibly private, fiercely independent and very proud. He had served his country well, and in retirement he had ran his own business, and he had traveled the world and was so proud of seeing the world not in a military framework, and his apartment was surrounded by beautiful things that he had picked up around the world. Unfortunately, John was diagnosed with metastatic prostate cancer, so it had already spread at the time of his diagnosis. And fortunately, as we know, people living with metastatic prostate cancer have a number of treatments that can help them and help extend life. And John really was interested in living longer and did well with treatments early on. He was taking hormone therapy, his pain was well managed with nonsteroidals. He did have to have a Foley catheter, which for some people is just a little nuisance. But in John's case, because of his anatomy and because he had to have it frequently changed, it actually became very cumbersome. So John adapted to a lot of things that he didn't really want to adapt to. He accepted he needed a cane. He accepted when he needed a walker. He even accepted when he needed a little bit of help with grocery shopping and his housework. But he was very clear and consistent about what he considered his hard lines. He did not want to have to leave his apartment and never wanted to have to live anywhere else, including a nursing home, in his case, at the very end of his life. And he did not want to have to accept personal care. It was his own personal values that he was very clear and consistent in articulating. So John's engaged in treatment. When the treatment stopped working as well as he hoped, he enrolled in hospice, and that's when he began to express his concern about the very end of his life and his interest in having the option to hasten his death if his hard line got crossed. So John completed the process for medical aid in dying in about 4 weeks, and he continued to live and to have hospice support until that day came when his circumstances were such that he needed to move or accept more personal care at home. And that's when he said that the quality of his life had diminished to a point where he no longer had meaning, and he wished to move forward with hastening his death, which he did so with his hospice nurse and a very close friend at his side. He self administered the medication and went to sleep very quickly within 10 minutes and died very peacefully in just under 2 hours. And I got a call later that day from the friend who attended the death with him, and he described what an incredible honor it was to serve his dear friend at such a poignant time in his life. And a couple of weeks later, I got a letter in the mail that was handwritten by John, thanking me for the ability to utilize medical aid in dying, encouraging me to tell his story, and to make sure that more people in our country had that right. Sonja, I'm going to hand it back to you.
Thank you, Diana. Thank you for sharing John's story. You've kept John alive through advocacy, sharing his story, his proud story, and honoring his autonomy and independence. So, what is medical aid in dying? Medical aid in dying is a medical practice in which a mentally capable adult with a prognosis of 6 months or less to live may request a doctor's prescription for medication which they can choose to self-ingest to peacefully end terminal suffering. There are few words highlighted here that I'd like to highlight and bring to your attention. Key practice is that this is our medical practice. We are still practicing medicine. And speaking with a community person and a loved one who's caring for a spouse, she spoke about death care. We often hear the word health care, but we rarely use the term death care. We are caring for human beings. We are caring for people as they enter end of life care. Mental capabilities. This is important in identifying someone who can make a sound decision on their own behalf. The desire and making the decision as to choosing to self-ingest this medication exemplifies and it highlights that this is a self-directed approach to someone's own care and journey at their end of life. And ultimately, what is our goal and what is the patient's goal? To end their terminal suffering peacefully. These words resound and stay close to my heart for reasons that we will highlight here and focus on here. The stopgaps, the creation of medical aid in dying, and the thought that goes behind why this is passed, why this is a necessity, and honoring and respecting everyone's wishes along the way. So where is medical aid in dying currently practiced? Where is medical aid in dying on its launching pad for passing? And where do we still have room for engagement, for advocacy, for awareness? As you can see, medical aid in dying is throughout many and a lot of jurisdictions. There are only 7 jurisdictions that have yet to ever bring it to legislation. There's still room and there's still time. Knowing that in Oregon in 1997 is when it first passed, and the ways that it has grown and reached to other jurisdictions is quite important. Delaware passed the 1st of January, and we are ready to educate, to launch, to grow, and to advocate here in our Delaware community. New York is still pending signature, and in Illinois, we've also recently passed the medical aid in dying laws. Knowing that there are still 7 jurisdictions, it is quite important for us to get an idea as to what is happening in Delaware, because in Delaware, things are happening differently in other jurisdictions. Each jurisdiction has its own unique way of carrying out this law, has its own unique way of abiding by its specific jurisdiction and honoring the patients that are in this territory. The details are quite specific. There may be some commonalities and there are unique features. Today, we will highlight what is happening in our Delaware state. Next slide. Before we engage in what is happening in Delaware and how we can enhance Delaware, it is very important for us to know what medical aid in dying is not. Keeping in mind what we addressed in our earlier slide as to what medical aid in dying represents and what it is, understanding what it's not offers us an opportunity to dispel rumors, misconception, and most importantly, fear. Medical aid in dying is not a substitute for best possible end-of-life care. It is not a failure on healthcare providers or our care for the patient. It is not a substitute for palliative or hospice care. I would say it is the opposite. It's an opportunity to engage and bring in all of these services to serve as a blanket of support and care. It is not suicide, and it is not euthanasia. It is not the same practice as we find in other countries, and is not the answer to all end-of-life suffering. For our Delaware eligibility requirements, you must be an adult. You must have an identified terminal illness. And this comes about oftentimes when someone has engaged or has accepted hospice care, understanding that their illness and their illness trajectory is terminal, and they no longer want to endure any untoward side effects, pain, suffering, or discomfort. A prognosis of 6 months or less to live. And you may hear there's a common message because this is the same information that we share when we're speaking about enrolling someone in hospice care and sharing the benefits of hospice care. Ultimately, and most importantly, someone who's electing medical aid in dying must be mentally capable of making informed medical decisions. You must be able to self-ingest these medications. They are not shared. They are not given to you. They are not forced upon you making this decision for your self journey. You must be a resident of Delaware. In some jurisdictions, this caveat does not require you to be a resident of said jurisdiction, but in our jurisdiction of Delaware, you must be an established resident. All of this must be confirmed by two providers: a medical doctor, a doctor of osteopathic medicine, and a nurse practitioner. The aid in dying medications. There is no required or standard prescription. The route of self-administration must always be considered, especially when we're caring for patients with neurodegenerative disease states and may have loss of limb, loss of ability to administer via a route that is most common to everyone. The mixture of the medications are designed to relieve nausea, anxiety, ultimately slowing your breathing and stopping your heartbeat. The time in which this occurs can vary between minutes, in some cases hours. The goal and the purpose is to align this medication or these medications to someone's comfort, safety, and peaceful death. It is prepared only by a compound pharmacy, so there's no drive-through CVS. It's a designated pharmacy designed to provide these medications in its utmost formulation and to hand it over to the patient. It is dispensed as a powder, mixed with 2 to 4 ounces of fluid at the time of self-administration. The antiemetic is offered 30 minutes, even an hour prior to the ingestion of the compound, days prior to the date of death and the date that you have established as a patient to ingest the medications. Patients are encouraged to ingest more liquid meals, less arduous meals that may, I would say, be quite heavy on your digestive tract. The goal is for an easy digestion to allow for an easy and a safe and peaceful death. Diana.
Thanks, Sonia. I want to shift just for a second to talk a little bit about what have we learned and what do we know about the practice of medical aid in dying, which has now been in several jurisdictions across the country. And as some of you know, Compassion and Choices does publish an annual report that gathers data from the states and puts it together as one resource. And we will send you those resources after the presentation. We've talked a lot about how every death is unique, and this is about meeting an individual person, but it is helpful to look at some broad numbers to let us know where we are. For example, the most recent report shows that more than 33% of people who had a prescription, so they became eligible for medical aid in dying, they had it in their back pocket as a plan B, but did not ingest the medication when they died. So that tells us that people want to live, people want to have a plan B in case things don't go as expected. And I think that that number represents a success in this story and demonstrates that medical aid in dying is just one tool of many that we want to utilize to support people at the end of lives. Next, we see that 89% of people who utilized medical aid in dying were enrolled in palliative care and/or hospice, that is a very large number and much bigger than the average palliative care and hospice use across our country. So again, it shows us that medical aid in dying is being embedded into the best practices of how to support people, and that people are tapping into all the resources they have, that multidisciplinary support of hospice and palliative care teams, of doctors and nurses and chaplains and social workers and aides and volunteers. And when all of that is enough and things are going well, people want to live. And when things start to not go well, that's when people consider utilizing medical aid in dying. And then just another percentage to share, about 79% of those people who use their medication for medical aid in dying did so at home. And we know from many different sources that the majority of people, not all, because there's always exceptions, but the majority of people really prefer to die at home. So medical aid in dying is allowing people the option, not telling them what to do. It's encouraging people to enroll in hospice and to be at home, which is really what we want for the best possible end of life care. Next slide, please. We do see, however, that some barriers exist, that there is always a balance of safeguards and barriers. And so for patients, where they live is still a challenge if you don't live where it's legal or can't access a state that allows you to come there. There are some providers who don't agree with active participation in medical aid in dying, and we know that that's okay, but it might present an extra challenge for the patient in terms of identifying and attending who will help them. From the physician or APRN perspective, we may see people who are uncertain or they're fearful or they're unaware of how best to meet the needs of a patient who's asking about medical aid in dying. And that's why we're doing presentations like this. For hospices, there are a variety of policies. There is uncertainty with hospice as well in terms of the federal law and the national landscape, and understanding how hospice very much can support patients and families in what it is that matters most to them. From hospital systems, we see that there are some providers who are not allowed to participate because of their affiliation or religious factors, and they may be uncomfortable or uncertain about how to develop a policy around how to incorporate medical aid in dying into their practice. So we're still learning how to do that. And then recognizing that the medications that we use to accomplish this procedure, first of all, they will change over time. But right now, they are required to come from a compounding pharmacy. And the truth is that there aren't many compounding pharmacies in our country, and it may be hard to locate. So safeguards are really important. Barriers we really are trying to address and find workarounds to. Let's talk a little bit about, again, just the process that happens when somebody wants to make a request. So again, this is a very broad overview, and I encourage all of you that are interested to sign up for the forthcoming webinars that will dive into this more. But very basically, I want to give you an overview of the law as a way of understanding that it is a very thoughtful, deliberative process. So the process begins when a patient makes an initial request to their attending provider. In Delaware, it could be a doctor, it could be an APRN. And generally speaking, if that person agrees, they're going to be the one that is supporting the process going forward. So they have to understand the patient's request, inform them about all of their options to treat their illness, and set up a second visit, because the person must make two separate verbal requests separated by at least 15 days, which is meant to be a waiting period to allow for reflection and assurance that interventions can't be done that would make the patient more comfortable and make moving forward with hastening death not possible. Unlike many other things in medicine, This process requires a second completely independent provider also evaluating the patient, determining whether or not they are eligible, assuring that they are capable of making an informed decision and that they are acting voluntarily. And if either of these providers has any questions about whether or not the patient has clear judgment and capacity to be able to make an informed, independent decision, then there is a mandatory pause and a psychological evaluation to evaluate whether or not the patient has capacity. In addition, there is a requirement for the patient to put their request in writing. Again, it's meant to be a safeguard and an opportunity for the patient to state clearly what it is that they are looking for and that they understand the consequences of taking medication that will hasten your death. So that is just a broad overview of the process. And as I mentioned before, along the way, the patient is being ideally evaluated by palliative care providers and hospice providers and being evaluated by their chaplain if needed, their social worker if there is distress, the providers writing the prescription, the support team from hospice, and a whole host of other practitioners to attend to any suffering that is on the table and identified and any intervention that can be done to make it better. I'm going to hand it back to Jessica now to go over some of the resources we have.
Thank you so much, Dr. Barnard, Dr. Richmond, for giving us that wonderful overview of how medical aid in dying works, specifically in Delaware. It's a complex process, but it is, like you said, very patient directed, and it is the patient that really stays in control from the beginning to the end. So there are a lot of resources that are available to professionals as well as to different folks in the community to really address some of these questions and to support patients through their journey. You heard Diana mention this is the first webinar in a series of 3 that is specifically tailored to medical aid in dying within the state of Delaware. So we hope that you will join us for our next conversation 1 month from now, which is really going to focus on how to respond to a patient's request. So when a patient comes to you and says, "Hey, I heard about this new law," or "This is something that I am interested in," then that will be what we're really going to dive deeper into. And then the third webinar in March is going to dive into considerations for practice. So the wide variety of things that go into the clinical practice of aid in dying care. For professionals, we have some brand new resources that are in the final phases of having being polished up. We will have a resource guide for clinicians that really focuses on the specifics of the Delaware law and aligns with the statute and the new regulations that are in the process of being developed with the Department of Public Health and the DHSS. So it will be able to serve as a useful and practical guide for supporting patients through the process, and also offer some considerations as within healthcare organizations you are considering the development of policies and guidelines and practice of this type of medicine. We also have a medical aid in dying information packet, which gives a nice general overview for anyone that's interested in medical aid in dying. That is already available on the Compassion and Choices website. And we also have a utilization report. Dr. Barnard touched a little bit on the data, who is using this, but some people might be interested in how this is working in other authorized jurisdictions. So our team does an amazing job compiling all of that data that is available to us and putting that together in an annual utilization report that also is available on the Compassion and Choices website. But no worry, we will be sending all of this out to you in an email, so you don't have to go hunting for it. We will be sending that to you shortly. The link for specific resources related to Delaware was just dropped in the chat in case you want to pull that up now. Compassion Choices has lots of other resources for end of life planning, end of life conversations, goals of care conversations. Our most popular is our My End of Life Decisions Guide and Toolkit, which is available for free download on our website as well. And we also have our Call Compassion. So, our end of life consultation service, our Compassion Legal program, a ton of expertise and professionals who are able to answer specific questions about whether that is yourself looking for information for family, or if you are a professional of any discipline looking for information on how to help a patient, how to support a client through the process. We are able to then kind of dive into the specifics of your situation and answer those questions and get you pointed in the right direction. So I hope you'll visit us at compassionchoices.org for that information. And as we said, we hope you will join us for our next couple of webinars. So at this time, we do have some time set aside for questions. I don't see that there are any in the Q&A at this time. So if you have a question, please feel free to choose the Q&A feature at the bottom of your screen and drop in a question for us. I see that there is one question in the chat that I'm happy to speak to, and that is regarding, I'm going to broaden it a little bit, Jean, if that's okay, and really talking a little bit about insurance coverage. Insurance coverage is one of those great things where the answer is it depends. So for folks that are enrolled in hospice, as you know, hospice is a Medicare benefit. The doctor's visits and the care that is provided should be part of the hospice plan of care and should be part of that. The individual doctor's assessments and those visits, so like with the attending and the consulting physician or APRN as a part of the aid in dying process, it depends. So some hospices, their medical providers will do those assessments as part of the hospice team and the hospice plan of care, and there is no separate billing. In some situations, it may be a provider who is outside, unaffiliated with the hospice, and that may need to be paid for privately. If you're familiar with hospice billing, you know that the rules are very specific and very tricky with what is allowed to be billed outside of hospice care. So it kind of just depends on the situation. But if that is something you'd like to discuss further, that is exactly the type of thing that our end of life consultation and our Call Compassion programs are able to assist with. Michelle has a great question. So there are compounding pharmacies in Delaware, great pharmacies, and we are in communication with them, as are other clinicians, to make sure that they have the tools and the resources and the information that they need. We do not provide a list of physicians. Honestly, most of the time, physicians are not interested to be on a list publicly. So that is something that we really encourage people to have a conversation with their physician or their nurse practitioner to talk about their individual situations. And I will say, with regarding pharmacy, that is such an important part of the aid in dying process, far more than just simply filling a prescription. Pharmacists have a very important role in this and are really part of the care team in supporting a patient. So we are looking to connect with pharmacists in Delaware and to be able to engage with them as well. So if you would like, please feel free to reach out to us. We would love to talk to you. And every pharmacy is different. Some will deliver medications, some do not. It really just depends on the pharmacy and the pharmacist and their practice.
Jessica, can I add something?
Yes, please.
Yeah, so I was just thinking of reminded to emphasize that this process, one of the ultimate safeguards is that it is voluntary for both parties, voluntary for prescribers and consultants, and voluntary for patients. So from a patient's perspective, They may just be looking for information, or perhaps they want to make a first request, but then decide they don't want to move forward or they want to pause. And that is completely okay. The entire process and the timeline is driven by the patient. And in fact, the prescribing provider has an obligation to remind the patient of their right to pause or stop the process at any time. Likewise, from a prescriber perspective, the process is voluntary, and there are many people, as you pointed out with your numbers, that support the practice of medical aid in dying, but may not be sure that they're comfortable actively practicing in terms of being a consultant or a prescriber. So, as Jess pointed out, it's never too early to ask your provider about this law, and if you were ever in need, would they be willing to consider helping you? And to remember that there's a reason that it is voluntary, and that some people won't feel comfortable prescribing until they hear a story that's really powerful and makes sense to them. So that's why storytelling and sharing your values and your concerns about the end of your life are so important.
Thank you so much, Dr. Barnard. Well said. While we're
Yeah.
at it, I have another question for you here that I think you mentioned earlier in the presentation, talking about the prescription. And we talked about that there is no one prescription for aid in dying, that it really depends. And Sonia, you touched on that as well, that it really depends on the patient, the route of self-administration. But we have seen the most common regimen prescribed evolve over time.
Yeah.
And Dr. Barnard, Dr. Richmond, would one or both of you like to touch on that a little bit about what drives those changes in the medication regimen, and just a little bit about what we've seen in that over time?
You can start, Dr. Barnard.
Yeah,
Sure.
I would, I think that this is a good time to mention that the practice of medical aid in dying, like everything else in medicine, is new, and it has evolved, and it will
Hmm.
continue to evolve. And the
Yeah.
clinical practice itself is largely informed by people doing this work. And
Yeah.
the Academy of Aid in Dying Medicine is really the organization that has been helping us figure out what is the best way to help patients accomplish what they are looking for, which is a swift and peaceful death. And so there are standards, and there have been at the bedside data collections that help inform which medications are the best to use in certain scenarios. And as we have said several times, we're really going to use the next presentation to dive more deeply into what that looks like and what are some of the resources as you begin to think about the practice, and what are some of the concerns that you should be keeping in mind.
Yes. To piggyback on Dr. Barnard's comment and insight, it is a constant moving the needle. Uh, Tried and true, I would say morphine has remained top notch, one of the most prescribed medications in the compound itself. As I shared in the earlier slides, the intended goal is to provide comfort, to place said patient in a state of unconsciousness, to address pain, to address comfort, anxiety, restlessness, and ultimately someone will die once these medications are fully digested, absorbed, um, in essence, leading to cessation of a heartbeat. I would say that the medications have worked very well across the board for a majority of the patients that I've been involved with, presenting with different terminal disease states. I remember all of the patients that I've cared for, as Dr. Barnard said. So it's like an ongoing assessment, an ongoing data collecting, and you recognize and you realize, well, this particular cocktail served this patient well, or this is what I encountered. And it's reaching out to your fellow colleagues, other prescribing doctors, reaching across jurisdictions as well, and engaging in said conversation. The more we speak about any hiccups that we may have encountered, any speed bumps that we may have encountered as clinicians, it helps us all with the information gathering. It helps us all with the care for the patients.
Thank
I
you
would
so much.
just add
Yes.
a very fine point, and Dr. Richmond is right that of the current formula that we are using, morphine is one component, but there are several components.
Correct.
And of course, whenever we talk about morphine, it is so important to understand that morphine is a very, very useful medication in much,
Yes.
much lower doses to help manage symptoms and help people live more comfortably while they are dying with a terminal illness. And we are not talking about those kind of standard morphine doses as
Hmm.
having the potential to hasten your death. And because there's so much misperception, I just want to emphasize that for a typical hospice use or palliative care use,
Oh, yeah.
much smaller doses of morphine can be very well tolerated and are acting in a different way.
Yes. Yes. You are correct, Doc. Yes.
Yes, I've seen it as well. We have
Thank you.
received a couple of questions about developing policies and also the request forms that the patient must complete as a part of the process. So, wanted to give you both a chance to respond to that. One very quickly, though, what I want to share first is just kind of where we are with that regulatory process. So, Delaware team, the state of Delaware, the Department of Public Health and DHSS, they are working and have been working for quite some time very diligently on thoughtfully drafting a set of regulations that further clarifies primarily the request form process as well as the data collection and reporting. The statute itself is very clear and is a wonderful guide to really outline what must happen, the responsibilities, all of that sort of thing. Um, Within that are the documents that the patient must complete and also that the attending and consulting providers must complete. So it is not up to individual hospitals or healthcare organizations to create their own forms, the
Yeah.
consent forms, the request forms. Those will be provided, and we should have the links to those very soon. We also do have resources on considerations and strategies and steps for going about developing policies, procedures, and practice that we are happy to share. We have sample policies, and I think it's helpful to look at policies that are specific to your care environment.
Yes.
And obviously, those are going to be very specific to each state because every state and jurisdiction has their own unique law. So, Dr. Barnard, Dr. Richmond, can you elaborate a little bit on your experience in being a part of creating those policies and making that decision for the clinical practice within the settings that you serve patients?
Sure. So in Washington, D.C., it's a transplant environment. So there are a lot of people who either work in D.C., are working there temporarily, and reside outside of the jurisdiction. So it's taking into account the sensitivity of jurisdiction and where people reside. That's most important and what was taken under consideration. And you must reside in Washington, D.C. district to utilize your medical aid in dying. I would say completing the documentation, it is a constant dialogue. Um, Working with the Department of Health and the guidelines and the guidance that's provided by the DC Department of Health has been quite advantageous, not only as a prescriber, also as the alternate doctor, and also as a community provider who is interested in and curious about this information and how to share this information with patients and families. The documentation in DC is literally one page, identifying said terminal illness, confirming 6 months or less prognosis, and also highlighting the importance of having the suitable mental capabilities of making an informed decision. It's a matter of checking a box and a matter of adding the content if and when there is someone who's on the fence and there's some concern about mental capabilities and capacity, first and foremost, you must have that clearance. And so then you pivot and you bring in an additional provider to join the journey of end of life care, of a peaceful death, and assuring that these parties make the decision that, yes, this said patient is of sound mind. The policies and the procedures, there's always consideration along the way. And sometimes I always say, I either win or I learn. So there's never a loss in any of this. There's always an opportunity to learn how we go about the creation of the policies, how we go about honoring and putting the patient in the center of the care that we are intending to provide. Dr. Barnard?
I know we're running short on time, so I'm just going to remind people that there are some complexities. There is policy, there's the clinical practice, and this work requires a team. And we are really fortunate to have a lot of teams, and Compassion and Choices has its own team. I am again going to mention the Academy of Aid in Dying Medicine as another team that looks at the clinical work, but I'm really looking forward to our future presentations because clearly there's more to cover.
Yeah. Yes.
Thank you both so much.
Thank you.
Again, we appreciate so much the time that you spent in with us today in learning about medical aid in dying in Delaware. We know there are lots of questions, and so we invite you to connect with us. If you are a clinician, a provider representing a healthcare organization, particularly hospice, we would love to connect with you. And I know we have a number of folks from Accent Care in Delaware here with us today. We would really love to connect with you. So please do feel free to connect with me directly, and we can certainly connect you with any other resources that you may need. We hope you will join us for sessions 2 and 3 as we dive deeper and answer even more questions. In the meantime, we would love your feedback. This QR code will take you to a very quick, simple survey. Shouldn't take you more than just a couple of minutes to give us your thoughts on today's presentation, but also let us know what are those questions that you have so that we can make sure that we are proactively addressing those in our future presentations. Again, thank you so much for your time. Look out for a follow-up email from us as well as this recording, and we look forward to connecting with you very soon. Take care.
Thank you.